All right, cool. I think let me get started. So I am JP da Costa. I'm one of the ED MOs at Helen Joseph Hospital. I was recently on rotation at Rahima Musa, and so tonight I'm going to be giving a presentation based on trauma in pregnancy. Hopefully my slides are more legible than my handwriting, but yeah, I think let's get going. So good evening, guys. Today I will be chatting to you guys about what is obviously a very important topic in the Rahima Musa Emergency Department. Trauma in pregnancy is often a presentation that we are quite fearful of, as not only do we have the welfare of the mother to take into consideration, we also have to consider the well-being of the fetus. Coupled with this, we know that sometimes even minor injury can result in fetal loss. This evening, I'll be outlining some of the common etiologies of this clinical presentation. We'll go through some of the important changes one can expect with pregnancy, take you through a broad approach to the assessment and management of these patients, and I'll also run through some of the common complications of trauma in pregnancy. So without further ado, let's kick things off. So in terms of the epidemiology of trauma in pregnancy, data shows that up to 50% of all maternal deaths in pregnancy are as a result of obstetric trauma. This alarming data is further complicated by the realization that domestic violence affects up to 11.1% of pregnant women. The table on this slide demonstrates that the estimated incidence per 100,000 births, as you can see, by far the most common mechanism of injury is indeed domestic violence, with the next most common mechanism of injury, MVAs, being a significant way off. So local data on this important condition is unfortunately limited. However, there is a study in Pietermaritzburg which analyzed data collected over 6 years. Of the 89 patients they saw in that period that had sustained trauma in pregnancy, 46 of these were victims of assault, 39 were taken to the ED as a result of road traffic accidents, and 1 was admitted as a result of a non-fatal suicide attempt. This again illustrates the high prevalence of domestic violence in this patient population. Blunt trauma constitutes the majority of trauma manifestations in pregnancy, that is 91%, which is based off of international data. Blunt trauma includes cases such as MVAs, PVAs, falls, violence, assault, and abuse. And penetrating trauma, which makes up the other 9% of cases, includes injuries such as stabbings and gunshot wounds. As previously stated, domestic violence is a common cause of visits to the ED. So when dealing with cases of trauma in pregnancy, we need to have an especially high index of suspicion for intimate partner violence. There are a number of physical changes that one can expect in pregnant patients. I thought a fairly good overview of just how much anatomical change we can expect inside a pregnant abdomen would be figure 1.1, a really cute dog that's had his face somewhat distorted by compression. The changes we see tend to follow a fairly predictable pattern. In the first trimester, there is a thick-walled small uterus in the bony pelvis. Later, in the second trimester, the uterus rises out of the pelvis and fills with amniotic fluid. This protects the fetus, but can lead to post-traumatic embolism, or DIC. Finally, in the third trimester, one will find that the uterus is quite thin-walled, and this puts it at risk from abdominal trauma. Other notable changes in pregnancy include that the bowel and diaphragm are displaced cephalad. This means that in some cases, penetrating injury can affect organs not likely to be affected in non-gravid patients. The bladder moves into the abdomen, so this organ is more susceptible to injury. Pelvic vasculature dilates, and the pelvic injury can lead to exsanguination. And we must also be aware that splenic injury is the most common cause of abdominal hemorrhage. Patients also have an increased risk of aspiration, and this is due to the low esophageal sphincter relaxation and physiological changes in pregnancy. In light of the anatomic and physiological changes seen in pregnancy, patients are also prone to rapid respiratory decompensation. Importantly, the IVC is compressed by the uterus, and this affects venous return. A key takeaway from this slide would be that one should expect an alteration in standard injury patterns when assessing patients. So the physiological changes in pregnancy are many, and we'll just go through some of the key ones. So in terms of the cardiovascular system, we're expecting to see an increase in cardiac output and heart rate with a lower systemic vascular resistance and a lower MAP. The respiratory system sees a normal respiratory rate, but tidal volume and minute ventilation are increased, but a reduced functional residual capacity. In terms of the renal system, we see a decrease in serum creatinine with an increase in GFR, and there's a compensation for the respiratory alkalosis that I'll be discussing in this presentation. Lab-wise, fibrinogen should be elevated, and if it's normal, you do need to consider the possibility of the patient being in DIC, and the white cell count is often elevated. In terms of blood, the hemoglobin in the hematocrit is often low as a physiological anemia, and the plasma volume is increased by 50%, which also adds a component of a dilutional anemia. There are increased metabolic demands, so early TPN should be considered and instituted for these patients. VBGs often tend to show a slightly lower PaCO2 as normal. There is a supine hypotensive syndrome, and that's as a result of compression of the IVC, and there is also a significant thrombosis risk. So when a patient presents to the ED, they may present stable or unstable. Stable patients may present with fetal loss, that is spontaneous abortion, pre-labor rupture of membranes, peripheral fractures, minor open wounds, or no injuries at all. Unstable patients may present in the following ways: with a uterine rupture, hemorrhagic shock, placental abruption, unstable fractures, syncope, or even maternal death. When approaching trauma patients, many people often find it helpful to begin by considering their overall impression of the patient and assessing which of these categories they may fall into. And this often guides doctors' degree of urgency and care. But in pregnant patients, if we choose to adopt this approach, we should consider following this assessment up by dropping a copy of Moore's clinically orientated anatomy onto our foot, because if you haven't picked anything up from the last few slides, all pregnant patients should be managed with a degree of urgency. And we should be aware that we should expect the unexpected in these patients. Now, before we rush into managing that pregnant trauma patient, we need to be aware that the key to managing cases of trauma in pregnancy is that we need to focus on maternal resuscitation. The only way to resuscitate the fetus is to resuscitate the mother. Improvement in the mother's condition will result in increased fetal oxygenation and perfusion, and hopefully a better outcome for both. Depending on the center, fetal viability is deemed to be at 24 weeks. Now, before we delve into this, rest assured that grossly, the principles of resus are as per standard ATLS guidelines. An interesting approach that I did find while researching this case was that of the ABCT plus UFO approach. That is, one would follow the standard ATLS ABCs. Thereafter, we should tilt the patient to reduce IVC compression and then attempt to assess the uterus and check for fetal tones. Another important consideration is that if the fetus is less than 24 weeks or non-viable, maternal well-being takes an absolute priority, whereas viable pregnancies need to have fetal monitoring as a consideration. So if we go through our old faithful ATLS ABCs, the first letter, A, is for airway. As a broad airway overview, you may have guessed this, but obstetric airways are notoriously difficult. Some data notes that these patients often have an incidence of difficult failed intubations, which is 4 times higher than that in non-obstetric cases. When assessing the patency of the airway, note that airways can be anatomically and physiologically more difficult. Therefore, one should try to keep the SATs higher, that is 95 to 98%, in expectation of potential complications at any stage. C-spine precautions should be adopted as normal, and important considerations are that we often see significant airway edema. There are often alterations in body habitus which can make cord visualization more challenging, and the airway tissue is quite friable, so aspiration risk is high, and we need a true, well-practiced rapid sequence induction to take place with a comprehensive difficult airway plan in place. These patients are often difficult to bag valve ventilate, and we should also have a wider range of ET tube sizes on hand, as well as suction that is readily available. As mentioned, we need to try to optimize the patient's SATs in light of a reduced apnea time. Apneic oxygenation is a concept often advocated for, and for more information on this, I'd recommend that you take a look at some of the work by Scott Weingart. Finally, as part of a progesterone-mediated pathway, we should expect decreased lower esophageal sphincter tone. Another contributing factor is the increase in intra-abdominal pressure. Combined, these two factors increase the risk of vomiting and aspiration, as if the risk of the other changes outlined above weren't convincing enough, these patients are at high risk of vomiting and aspiration. In terms of drugs, I've divided this slide into first-line agents and second-line agents. This is based off research which takes into consideration the physiological changes in pregnancy, as well as teratogenicity and risk to the fetus. In our resource-limited setting, we're not often going to be lucky enough to have cis-atracurium, so rock and sucks may have to suffice. Progressing to B for breathing, we need to ensure adequate oxygenation and ventilation. And here, think back to the physiological changes that I described earlier. This involves early use of supplemental oxygenation as appropriate. The enlargement of a patient's breast tissue, coupled with the decreased functional residual capacity and aspiration risk, can make ventilation quite a bit more difficult. One other factor to consider is to place an orogastric tube when possible to minimize the aspiration risk and to reduce diaphragm splinting. Furthermore, as I touched on earlier, a normal PaCO2 of 35 to 40 may actually signal impending respiratory failure in this subset of patients. Patients often have a lower PaCO2 due to hyperventilation, and a normal PaCO2 may be closer to 30. Increased hyperventilation frequency often causes a respiratory alkalosis on our VBGs or ABGs. Finally, just a reminder that there is an increased oxygen demand due to the metabolic requirements of the fetus. Now, a common complication of thoracic trauma is that of hemothoraces and pneumothoraces. Due to the anatomical changes in pregnancy, we need to place our ICDs 1 to 2 rib spaces higher, and due to the diaphragm rising and compensatory flaring of the ribs, these patients are predisposed to pneumothorax and may have a faster progression to tension pneumothorax. Management of circulation in these patients is of paramount importance, as subpar management can result in fetal hypoperfusion. Off the bat, aortocarpal compression can reduce the stroke volume and the cardiac output by 20%, and this reduces maternal perfusion significantly. Furthermore, the fetus may be hypoxic even if the mother appears to not be hypoxic. Additionally, due to physiological changes, patients may lose up to 45% of their blood volume before showing clinical features of hypovolemia. This often results in a significant underestimation of fluid losses. So please take note of this. Beware of using the patient's vitals as a guide for the adequacy of your volume resuscitation. Patients should receive the standard fluid management as per ATLS guidelines, and most recent evidence suggests that manual displacement of the uterus is more efficacious than left lateral tilt. Bleeding should be managed per ATLS guidelines. Patients who are over 20 weeks pregnant without ROSC in 4 minutes should have a resuscitative hysterotomy performed to improve outcomes, and O-negative blood should be given until the rhesus status of the patient is confirmed to prevent isoimmunization. We should also try to avoid the use of pressors if possible, as we see that these often have worse outcomes and cause constriction of the placental bed, which increases fetal hypoxia. In terms of disability, where patients present with seizures, we need to consider eclampsia as a cause. We want to avoid epilim and phenytoin due to risk to the fetus, and we'll touch on drugs that you can use shortly. We also need to do the standard examinations for any neurological fallout. Exposing the patient adequately is key, and we need to seek out other injuries. Importantly, don't ever forget glucose. Take note that peritonism is also unreliable in pregnancy, so we always need to investigate abdominal pain further. While conducting our secondary survey, we should look for factors which may influence our patient management. These include multiple pregnancy, PV bleeding, cervical changes, ferning on microscopic slides, suggestive of rupture of membranes, and pelvic bone protrusion. So beware of sharp fragments when conducting PV or PR exams. In patients with respiratory distress in the absence of chest trauma, consider that they may have pulmonary edema in preeclampsia or an amniotic fluid embolism. Also look for comorbidities which could influence patient presentation, such as preeclampsia or HELLP syndrome. And importantly, you also want to have early gynecological involvement. Finally, our tertiary survey would include abdominal pad and PV checks. CTGs and serial ultrasounds may be indicated, and rhesus immunoglobulin may be indicated, as may thromboprophylaxis. MDT involvement of OBS, PEDS, and trauma is generally indicated. Now let's take a look at some of the considerations to have when considering imaging the pregnant trauma patient. It's time for a throwback to our med school days. Does the acronym LARA ring any bells? So all patients should have radiation that is as low as is reasonably achievable. This involves reducing the time of exposure, increasing the distance of exposure, and making use of shielding to limit effective radiation exposure. Medico-legally, wherever possible, we should also try to obtain consent for imaging in these patients. It's important to consider a benefit versus risk analysis for all patients. Now, when dealing with radiation, I would be remiss not to mention two key concepts, that of absorbed and effective dosing. So the absorbed dose is the amount of ionizing radiation that is absorbed by the patient, and the effective dose indicates the radiation health effects for a population and is influenced by the type of radiation, the organ sensitivity, and a number of other factors. In the following slides, I'll be referring to the absorbed dose, as this is a constant value that we can bear in mind when considering which imaging modality to use. When imaging, the patient's highest risk from exposure is in week 2 to 7 of pregnancy. That being said, it generally takes more than 50 milligray to harm the fetus at any stage in development. Chest X-rays normally only expose the patient to 0.001 milligrays of radiation. A CT pelvis is much higher, or much higher risk, but it's still only 25 milligrays of radiation. This means that in cases where it's indicated, we should not be afraid to perform the necessary radiological investigations, but still follow the principles of ALARA. With pelvic X-rays, as mentioned earlier, you may see widening of both the SI joint as well as the symphysis pubis. This should obviously be interpreted with consideration of the clinical condition of the patient. Should a pelvic binder be indicated, please do still place it. A lot of textbooks still list diagnostic peritoneal lavage as a means for assessing for free fluid, but this is a high risk and low yield investigation. Those who know me know that I love a good ultrasound. EFAST is an important point of care test to conduct, and pregnant patients are no exception. There is surprisingly not as much research as I would have expected on this issue, but anecdotally we're told that EFAST sensitivity is reduced in pregnant patients. I'll come back to this point on the next slide though. Now, if you look closely enough, you may be able to identify a subchorionic hemorrhage, which is suggestive of a placental abruption. Experienced sonographers may be able to notice intracranial hematomas and skull fractures. And key features to note on your ultrasound investigation include the gestational age, fetal heart rate, fetal activity, the placental location, and amniotic fluid volume. As alluded to earlier, anecdotally, we're told of EFAST's reduced sensitivity. Despite this common perception, the evidence that I could find, albeit limited, reports that there is no significant difference in sensitivity or specificity. With regard to blunt abdominal trauma, the sensitivity of FAST in detecting intraperitoneal fluid in pregnant blunt trauma patients was 83% in a study that reviewed 127 trauma patients. This rate is similar to that in a previously published study of non-pregnant trauma patients. I think this is an important consideration for us to be aware of and something that we should keep an eye on for further research in this particular subset of patients. Now, with regard to monitoring, we have objective and subjective tests. In terms of objective monitoring, which is often regarded as being more reliable, the general consensus is that if they are less than 24 weeks, no fetal monitoring is indicated, but they should still be seen by an obstetrician. And if they're more than 24 weeks, a CTG is indicated. Monitoring should generally be for 4 hours and extended to 24 if there are more than 3 contractions per hour, uterine tenderness persists, the results of the CTG are concerning, there is a PV bleed, membranes rupture, or serious maternal injury. Signs of fetal distress could include an abnormal baseline, decreased variability, late or variable decelerations, frequent uterine contractions. After discharge, you can ask the mom to record fetal movements for 1 week, and if they are less than 4 per hour, they should have an urgent obstetric review. Other investigations to consider include a preeclampsia workup and coagulation studies to rule out a DIC. An important test to be aware of is the Kleihauer-Betke test. So this tests maternal blood for fetal hemoglobin, and it's an indicator and quantifier of feto-maternal hemorrhage. Still recommended, but there is questionable reliability of the study, and basically it will dictate whether you need to give higher doses of rhesus immunoglobulin. Unfortunately, the results are not immediately available and are not, fortunately, immediately needed in ED, as a majority of rhesus isoimmunization is prevented by giving the maximum dose of rhesus immunoglobulin. Failure to administer this can have serious complications. Rhesus immunoglobulin is indicated in all rhesus negative patients with significant abdominal trauma. Its administration is time sensitive and it should be given within 72 hours of the injury. Dosing is 50 micrograms in the first trimester and 300 in the second and third trimester. And complications include severe fetal anemia, fetal distress, stillbirth, and hydrops fetalis. In terms of medication use in pregnancy, tranexamic acid is unfortunately still contentious as it was excluded from a number of key emergency medicine studies. It's currently classed as a category B medication, but it is considered likely to be beneficial. Anti-tetanus toxoid and rabies immunoglobulin is safe in pregnancy, and if you're going to be writing your DIPIC anytime soon, please pay attention to that. Antibiotics should be given early to avoid infectious complications. Steroids should be given for fetal lung maturity in preterm labor, and tocolysis is generally something that should only be given in consultation with the obstetrician on call. There is some research with regard to tranexamic acid use in obstetric patients, but it's mostly related to PPH and other obstetric complications more than trauma in pregnancy. So it was found that tranexamic acid reduced death due to bleeding in women with postpartum hemorrhage with no adverse effects. And when used as a treatment for PPH, tranexamic acid should be given as soon as possible after bleeding onset. As mentioned, the CRASH trial specifically excluded pregnant patients. Several commonly used anti-epileptic agents have been shown to be teratogenic, and these include phenytoin and epilim. The evidence that I could find supported the use of Keppra as a preferred anti-epileptic agent, and you would use this once eclampsia has been excluded. Mannitol use should be carefully considered and discussed with a neurosurgeon, as it can cause a hyperosmotic state in the fetus. With regard to analgesia in these cases, first line is obviously paracetamol, with opiates constituting the second line choices, and NSAIDs should be avoided as they may cause spontaneous ductus arteriosus closure, which has a possible association with spontaneous abortion in trimester 1 and trimester 2. Complications that we may see as a result of trauma in pregnancy include placental abruption, APH, uterine rupture, PROM, red blood cell isoimmunization, and fetal injuries. So placental abruption is the most common serious complication of obstetric trauma. Essentially, there is a high amount of energy transfer and the uterus moves, but the placenta doesn't. So the placenta is sheared off the wall of the uterus following the impact. The mother may have no visible signs of trauma, and cases generally occur after 20 weeks. The mother may present more than 24 hours after the injury. Patients often present with severe abdominal pain, PV bleeding, reduced fetal movements, shock, cramps, uterine tenderness, and fetal distress. Note that the absence of pain doesn't exclude abruption, and this abruption is a clinical diagnosis. So even minor trauma can cause significant shearing forces, and these cases may need CTGs. Specific indications for CTGs include any viable gestational age with a suggestive mechanism of injury. If both the mom and the baby are stable and it's a partial abruption, that is less than 25%, close monitoring and delivery at 32 weeks is indicated as expectant management. And then if they are unstable, more urgent management is indicated. Fetal complications can include perinatal asphyxia, intrauterine fetal death, cerebral palsy, and preterm labor. And maternal complications can include DIC, shock, and an increased PPH risk. Just a fun fact is that the uterine artery can bleed more than 600 mils per minute. So you are working with time constraints here. And then if there is a PV bleed, please also just remember to always ultrasound the patient to exclude placenta previa before conducting a PV examination. Preterm labor is another common presentation, and it's defined as premature, that is before 37 weeks, onset of labor, and can be precipitated by placental abruption, maternal hypoxia, and bleeding. So it's generally going to be seen with more than one contraction every 15 minutes with accompanying cervical or cervical changes. And then the myometrial and decidual cells release prostaglandins, which stimulate uterine contractions. And this process is dependent on the extent of the damage, the gestational age, and prostaglandin release. Pre-labor rupture of membranes can occur after trauma, and you will see lycodraining with a ferning pattern that I showed you on a slide earlier. Uterine rupture tends to occur after high-energy trauma and can rarely be seen after stabs or gunshot wounds. There's a differential of a fractured liver or spleen, and it's fortunately a relatively rare presentation. Symptoms include shock, peritonism, palpable fetal parts, and absent fetal heart rate with free fluid in the abdomen. Management depends on the extent and the future childbearing potential of the patient, with options including suturing of the tear versus complete hysterectomy. Another important issue is that of fetal injuries, and the majority of fetal injuries occur in the third trimester. These are often associated with pelvic fractures or penetrating trauma in the mother. Risk factors for fetal death include ejection, motorbike accidents, pedestrian vehicle accidents, maternal death, maternal tachycardia, and abnormal fetal heart rate, the lack of restraints, or an injury severity score more than 9, and common maternal derangements or presentations which may result in ischemic damage to the fetus include maternal acidosis, hypoxia, and hypotension. Now, the key to this slide is that patients not wearing seatbelts are 3 times more likely to see fetal death. And in light of this, salient points on your history should include the velocity of the accident, airbag deployment, and the use of restraints. Resuscitative hysterotomy, or perimortem C-section, is performed in patients more than 24 weeks pregnant, and the focus is on maternal resuscitation. Prompt obstetrics and pediatric involvement is indicated, and there is generally an increased ROSC in the mother due to reduced aortocarpal compression and improved pulmonary mechanics. If there's no fetal heart or maternal heart, we'll likely terminate resuscitative efforts. Just a quick overview of the technique that you'll adopt is, firstly, you'll sterilize the site. You'll make a midline incision from the xiphisternum to the pubis through the abdominal wall. You'll expose the uterus and reflect the bladder inferiorly, and then vertically incise the uterus about 5 centimeters and open bluntly to minimize the risk of fetal injury and clamp any bleeders. You'll deliver the child and continue resus while awaiting OBS and gynae. So this is a nice summary of everything that we've spoken about that was posted by Tammy a while ago from the South African Resuscitation Council. It essentially just goes through your hazards, hello, health that we should all be familiar with. It then goes into your hemorrhage control and talks about the use of tourniquets, binding the pelvis, straightening or stabilizing long bone fractures, as well as IV or IO access and bolusing of patients. It then goes into oxygenation and ventilation and advocates for advanced airways where indicated, as well as ventilation. If the patient has a tension pneumothorax, they'll need bilateral decompression and drains. Tamponade may warrant a thoracotomy or a pericardial window. And if there is no ROSC, consider termination of efforts or else follow the post-cardiac arrest algorithm and administer tranexamic acid while involving the surgical team. So key points from this talk were just that resuscitative efforts should have a maternal focus. There should be timeous obstetrics, gynecology, and trauma surgery consultation. We've spoken about the use of rhesus immunoglobulin, intimate partner violence screening, prompt perimortem C-sections where indicated. We've spoken about manual displacement and the fact that it's preferred to the left lateral tilt. We shouldn't rely on maternal vitals to guide resuscitation, and we should be aware of normal PaCO2s, or the pseudo-normal that we spoke about. And then finally, just some references that I made use of when compiling this presentation.